Hello, YouTube. This is Mark Takalowski with Otsuka Pharmaceutical Development and Commercialization. Recently, PsychU hosted a webinar titled The Use of Digital Tools for Serious Mental Illness and Substance Abuse. During the discussion, our speakers described the digital treatments and new technologies for treating major depressive disorder, schizophrenia, bipolar disorder, and substance use disorder. As always, the presentation was sponsored by Otsuka Pharmaceutical Development and Commercialization Incorporated and Lundbeck LLC, committed supporters of the mental health treatment community. Speakers are paid consultants to OPDC, and I am an employee of OPDC. Let's look at a few clips from the webinar.
There are some other things in kind of out there land, and one includes using virtual reality to do various homework assignments and interventions. And of course, 10, 15 years ago, virtual reality was implemented in the management of several anxiety disorders, but there are now adaptations and modifications to make homework assignments in the course of cognitive behavior therapy also possible using virtual reality through, for example, an activity schedule or another kind of assignment. I think it is also possible to improve diagnostics using modern computing power. And of course, the poster child of this is something called machine learning, in which very, very subtle tendencies in large data sets that are incomprehensible to normal human thinking and not computable in terms of old-fashioned ways of analyzing data. The machine learning strategies really have made it possible to see new subtypes or new subforms of illness and individual group differences that are important to individuals in terms of treatment outcome.
So again, we've got some apps and wearables that can do some pretty neat things if the right computation is applied. So identifying cravings and tracking substance use. So those are some of the most critical aspects to substance use treatment. Assessing stress levels and mood, those can also be predictive factors in a person who's relapsing. Looking at the activity level, sleep patterns, and then looking at treating the withdrawal symptoms by neurostimulation. Because if someone does have a relapse and wants to get clean again, that withdrawal can be very difficult, and with some potentially reduced availability of in-person detox services and to be able to manage the withdrawal, it can be very difficult for someone to, even if they did have the motivation to stop, to actually make that leap and get back on the wagon. I really like this next one, which is using GPS to warn people they go near a high-risk place. So think about it as kind of geofencing. If someone drives past their dealer's house, and even when they're clean and that triggers them, a bar that they used to go to, whatever, well, there's the potential to set a radius. Could be a mile radius, a 5-mile radius, 10, whatever you want the threshold to be. And if you're driving and you happen to get within that radius, it can send you a notice. Hey, reroute, you're getting too close to a trigger area. That's something that the person might not be aware of until it's potentially too late. So setting a fairly wide radius could really help them to avoid some of those triggers that could lead them down the wrong path. And then the last one, also really cool, measuring alcohol level transdermally. So we do have ways by breathalyzers, obviously, to check alcohol levels, but that's an active technique, whereas a transdermal patch could passively monitor the alcohol level. And anything that you can take from active to passive is going to increase the acceptance and increase the adherence. And not to mention, hopefully has good adhesion in addition to adherence when we're talking about a patch, pun intended. But having that passive monitoring of the alcohol level, again, someone could avoid using a breathalyzer if they know that they've had some alcohol. But if the patch is on, they might get picked up because the person could leave it on.
Some of these technologies are sort of out there. For example, the smart shirt. I don't own any smart shirts, I have to say, but maybe at someday I will, because you can wear a garment that actually provides monitoring of your pulse rate, your respiration rate, and can, in fact, give clues about your overall well-being. Interestingly, there are kind of home-based biofeedback devices now making use of headbands to monitor kind of dominant frontal EEG rhythms, and this can be used as a tool to help people learn to do yoga or meditation in order to kind of tune down one's level of dysphoric apprehension. I also don't have a pair of socks with sensors, but this has been described as a way of keeping track of kind of heightened arousal, because our feet are an area that sweat kind of more so in relation to just how activated or apprehensive we are. And then, of course, psychomotor retardation does include speech. And there are computer programs available that can, by virtue of the variation in tone and the rapidity of one's verbal output, can give reasonably good appraisals of whether one's mood is going on the high side or going on the low side based on those verbal indicators.
So before the pandemic, most SUD treatment, like all psychiatric treatment, was in person. And this makes even more sense when you think about substance use disorders. There's a law called the Ryan-Haight Act, which many of us had probably never heard of before the pandemic, but it gained some limelight during the pandemic because it did require controlled substances to not be initiated unless the person had been seen in person ahead of time. At the very beginning of the pandemic, when we just started switching, most of the patients we were seeing were our patients who've been in our practices already, but inevitably we're coming up on 2 years now, and obviously we've seen new patients in practice. And if the Ryan-Haight Act had not been relaxed because of the declaration of the public health emergency through COVID-19, then it would have been illegal actually to prescribe those patients who we had first met through telemedicine a controlled substance. So fortunately, that's been made available to us. But much substance use disorder treatment with things like opiate agonists, et cetera, involve controlled substances. And so obviously that would have been nearly impossible to initiate for a new patient to telemedicine prior to this relaxation with Ryan-Haight.
Thank you for watching our YouTube teaser. If you'd like to watch the entire presentation on psychu.org, please click the link on the description. You can take a look at our upcoming webinars while you're there as well. Be sure to follow us on Twitter, LinkedIn, Facebook, and Instagram, and have a great day.